Good afternoon. We're going to give folks just a moment to join the webinar and then we'll get started. So welcome to today's webinar. Today, we're going to take a closer look at a practical guide to building and growing a cardiac PET CT program. I'm Denise Bushman, Vice President of Care Transformation with MedAxiom, and I'm joined today by Jamie Warren, partner in crime with me. She's also Vice President of Care Transformation with MedAxiom. We're especially grateful today to CDL Nuclear Technologies. They're the foremost provider of cardiac PET CT solutions in the US, and they sponsored our new white paper, Scaling Excellence, a practical guide to building and growing a cardiac PET CT program. With us today to share a lot of expertise is Dr. Rupa Sangani. She is the Grace DeForest and William Lewis Beck Endowed Professor of Cardiovascular Research, as well as the Director of Nuclear Cardiology and Stress Lab, the Section Chief, General Cardiology at Rush University Medical Center. She's a busy person, and just to add to that, she's also on the Board of Director for ASNAC, where she chairs the PET Committee. Also joining us today is Brendan Loisel. He is the Chief Business Development Officer for CDL Nuclear Technologies. Next slide, please. These are our disclosures for today's presentation. And then what I'd like to call your attention to here is just a few housekeeping details. During the webinar, if you have any questions, please just type them in the Q&A section that you see at the bottom of your screen. We'll make sure to leave time at the end of today's presentation so we can have some discussion with the panelists and with myself and with Jamie. And so that hopefully will leave you enough time to just place your questions there in that Q&A section. You'll also find a few items in the chat. So that's where you'll find a copy of today's presentation. You can download that directly from the link that you'll see in the chat. And then in addition, anyone who's registered for this webinar will receive a link to the recording within about 3 to 5 business days. So if any of your colleagues registered, but something came up and they're not able to listen in today, they still will receive a link to listen to that recording, as well as it will be available on the MedAxiom website. And then there will also be a link to go to a copy of the white paper that you can download if you'd like to read it in its full detail. So now, without further delay, I'd like to hand the meeting off to Dr. Sangani. Thanks for being with us.
Thank you very much, Denise, for that kind introduction. So I'll start off with a question that I want you all to think about, which is, what if we could offer our patients a more accurate, faster, and safer cardiac imaging option while also boosting our hospital's bottom line? I'm going to start off today with discussing the clinical benefits of cardiac PET. Next slide. So when we think of the clinical superiority of cardiac PET, it's really in the higher energy emitting isotope and its ability to provide consistent, high quality, high resolution images. And because of that superior diagnostic accuracy, you are less likely to get those equivocal studies that we see often in SPECT. They are either definitively normal or definitively abnormal. And that reduces the need for follow-up testing and provides, of course, increased confidence in the results. Next. Now, the beauty of PET, though, is really the integration of these 4 key clinical features. We've just talked about the robust relative perfusion. Now, the images display very similarly to SPECT, but given the higher resolution, it mitigates much of the attenuation issues that we are concerned about with SPECT imaging. Next is the ability to have a true stress ejection fraction. With rubidium and ammonia imaging, because we are, or with any vasodilator imaging, I should say, when we are imaging under stress conditions, it is under the camera. And so you actually get to see how the ejection fraction and the heart responds to stress, and that A normal EF should really augment robustly. When it doesn't, or if it drops, it is shown to be correlative with the amount of ischemia, the number of vessels, and with cardiac death. Third is the calcium score. Majority of our cameras these days are a PET-CT, and being able to actually do a quantitative Agatston score with a dedicated calcium score, or even just a qualitative assessment on the CT-AC images, really changes your diagnosis, because if CAC is present, it solidifies that there is atherosclerosis in this patient. Whether or not there's ischemia or not, there's definitely atherosclerosis present. And finally, it's absolute flow MBFR. And this is probably the most exciting part about PET. Being able to actually quantitate flow and flow reserve adds an incredible level of diagnostic accuracy and insight into both macrovascular and microvascular disease that we have not been able to assess before. When I integrate all four of these, this really allows us to have comprehensive risk assessment in the symptomatic intermediate risk patient that we're referring to PET. Next, so let's talk about reserve, because I think most part we blood studies, the software image takes the amount actually pool using very fancy genetic modeling, also looks at the amount of blood that's taken up into the myocardial contours, and is able to see how much actual MBF or flow is there at peak hyperemia divided by the amount of blood flow at rest to calculate a flow reserve. Now, in general, a normal flow reserve is considered to be above 2. There are different cutoffs for tracers, what's abnormal and how abnormal. Next. When we look at a flow reserve, it's very important to understand where these numbers come from. We're looking at the flow at the tissue level of the myocardium. On the upper right, you can see our schematics of the coronary tree. In the past, we focused so much on the epicardial 3 arteries because that's what really dictates who goes to cath. However, 2/3 of the coronary circulation is in the microvascular space. So when you look at the middle picture, our flow reserve really is an evaluation of both the macro and the microcirculation. So everything from those large arteries down to the capillaries. And that flow reserve number provides an integrated marker of coronary vasodilator dysfunction. When abnormal, it could be due to disease in the large or the small vessels, focal disease, diffuse disease, or some combination. And it's the subtleties of looking at the other parameters that help us differentiate this. But when flow reserve is normal, I feel very reassured that everything along this coronary tree is normal. Next. And that takes us to this paradigm shift that we've seen in cardiology. We have moved away from always referring to ischemia as just obstructive coronary artery disease, which only evaluates the 3 large epicardial arteries, to now ischemic heart disease, which really encompasses the full burden of disease. That includes those patients with non-obstructive and diffuse CAD, microvascular disease, and spasm. And although now our test may not necessarily be a gatekeeper to cath and whether they should receive further intervention, but it does give prognostic information on how high risk this patient is and how much more we need to intensify their medical therapy. Next. Who benefits from a cardiac PET scan? Well, the American Society of Nuclear Cardiology and the Society of Nuclear Medicine and Molecular Imaging put out a position statement in 2016, which stated that PET is preferred really in anyone with known or suspected CAD who meets appropriateness criteria for a pharmacologic PET study, unable to complete exercise stress, and that there was really no clinical scenario where PET was not considered preferred if it was an appropriate study. This is being re-looked at, of course, with the new tracers and the ability to do exercise, but this is a great place to start, both for your centers, your administrators, and for your insurance companies to understand the importance of PET and where a patient might benefit. Next. For our patients themselves, what do they experience? Well, I think the three key points is that it's faster, safer, and better. PET is a rapid protocol. The entire study can be completed in approximately 35 to 45 minutes, whereas compared to SPECT, which is about a 3-hour-long procedure. There's a significantly lower radiation dosage with PET. Depends on the tracer that you use, but it can be up to a third to a fifth less reduction in radiation. And a lot of this is, of course, the higher energy isotope leads to the better quality imaging resolution. It is now available to be performed with exercise or pharmacologic imaging. And there are 3 different FDA-approved tracers and models available. Lastly, the addition, as I've already mentioned, of a calcium score adds significant input for the patient in actually documenting their atherosclerosis that may then change their medical therapy in regards to aspirin and statin therapy. Next. What are the uses of cardiac PET? Now, of course, myocardial perfusion imaging is the workhorse of cardiac PET. But even within myocardial perfusion imaging, we can now assess both disease at the macro and the microvascular level, as we've already discussed. This is quickly becoming, along with MRI, the gold standard for myocardial viability. Thallium SPECT is outdated, poor quality images, and gives a much higher radiation exposure to our patients. Sarcoidosis could be used in your lab as another great way to use cardiac PET. And the horizon really is using it for inflammation imaging. There's been a lot of interest and early research on using this for endocarditis and for myocarditis imaging. We'll move on now to a case scenario to highlight some of the importances here. So I have a 70-year-old woman who presented with exertional shortness of breath. Her baseline activity is poor. She did have SPECT MPI imaging at an outside hospital and was told that it was normal, and so was referred for further evaluation as she continued to have shortness of breath. Next. So you see here her images on the top right. Very mild, moderate lateral ischemia. Her sum stress score was deemed to be 6. There was borderline transient ischemic dilation, which is a higher risk marker. The EF at rest was 78% and dropped to 71% globally. Now, it was still in the normal range, but there was a 6% drop in ejection fraction with the vasodilator stress. And you can see on the calcium score on the pictures in the dark green here, in the neon green, CAT was very high, 1525, with a strong left main and proximal vessel predominance. Her flow reserve was diminished through all 3 segments, 1.31, 1.0, and the RCA at 1.6 with a global flow reserve of 1.3. Next. When I look at this study, the key points that I would ask you to take away is the high calcium score establishes the presence of coronary artery disease and atherosclerosis. We know there's atherosclerosis there. The abnormal MFR, despite a normal or a mild perfusion, now reclassifies this study from low risk to high risk. And the combination of the low MFR with the high calcium now increases your suspicion for significant obstructive disease and concern for balanced ischemia. This patient was referred for cath. Next. And you can see that she did indeed have both ostial left main as well as distal left main / prox LAD disease. And so our PET scan was consistent with this, and by the addition of the calcium and the flow reserve really raised our suspicion that what was just mild defects on relative perfusion was now consistent with a higher risk patient that needed further investigation. Thank you for your attention. I'll turn the next session over to Jamie.
Thank you, Dr. Sangani. Thank you for helping us with the why behind cardiac PET. And let's pivot now to the how. Next slide. Because it's one thing to know about that PET is clinically superior, but it's another to actually stand up a successful program. And what we've seen across organizations in the transition isn't necessarily a straight line. It's a little bit more of a roadmap. And you may see that you find some barriers that you run into. Next. The key is turning those into opportunities by leaning in on strategy, teamwork, and adaptability. Next. So for the next couple of slides, we're going to walk through what those barriers usually look like and the lessons we've learned from helping groups move past them. Next. So in our pie chart here, the first that we see is cost and capital investment. PET feels expensive, and that can make leaders hesitant. The second is infrastructure, and sometimes it's space or long construction timelines. Third is staffing and training. Teams need to learn a new workflow and build confidence with new protocols, especially with myocardial blood flow. And then finally, with regulatory approvals, this is looking at your state radiation boards and NRC processes, as this can slow everything down. Now, sometimes these barriers can feel like a brick wall, but as we will see, they are able to be overcome with the right strategies. Next. Setting up a PET program is more than just equipment and space. It's about people and process. It's first, you're going to need to really evaluate which is your true A team. And this means not just your physicians, but really looking at the complete team with your technologists, your nurses, administrators, and even physicists when needing. Everybody is going to play a role here. Second, radiology collaboration is critical. Incidental findings will come up and you need a system for seamless handoffs. Third, aligning your workflows. If scheduling, billing, and pre-auth aren't optimized, it can derail even the best clinical program. And last, staff training on myocardial blood flow. This is where the value of PET comes alive. It's the game changer for adoption and clinical impact. And now I'm going to hand this over to Denise.
Thank you, Jamie. Appreciate that. What I'd like to do is just walk through a case study that's included in the white paper that we think is instructive to understanding how we really can adopt PET with things that are really out there. It's a real world, and that's what you're faced with when you're thinking about how to face these kind of challenges. So we like to use a case study to say, here's the real world, how do you deal with it? So the case study that we highlight in the paper is in regards to a large health system. And their situation was that they had a PET system that they'd been using for like almost a decade, and now it was retiring and they needed to replace it, but there were construction delays. And when you have delays with this new suite, what that meant was a serious risk of care gaps for their patients, their providers accustomed to being able to have the benefits of PET that you just heard about, were then we're faced with the inability to provide that level of care. So instead of halting patient care, they went in search of finding a solution that would fit their needs. And they found CDL because CDL would provide a mobile PET CT unit for them that could help them bridge that gap. What happened was the unit integrated seamlessly with that local staff and with their workflows. They could back the unit right up. So it really became an integral part of the hospital itself. You almost didn't see the difference in moving from the hospital into the mobile unit. So instead of losing ground, what they actually did was they gained some efficiency, because as they learned with the new equipment, they not only could become accustomed to the new workflows and being trained with that, but they also were able to see 2 to 3 more patients per day. So it really, by using that system, by the time the new suite was ready, the learning curve was already pretty flat. So it wasn't really a bridge solution. It helped launch them into the next stage of the use of PET CT for their program. So what we know is that there are important operational impacts of PET. And this is really where PET shines for us in programs. The scan time, if we look at that, what you'll see, the scan time alone, we're talking about 30 to 45 minutes versus up to probably about 4 hours if we talk about SPECT. And that shift in time not only frees up capacity for the number of patients you can see, but will dramatically improve that whole patient experience, what it feels like for to be in their appointment, because the appointment is shorter, certainly more comfortable and less burdensome overall for patients. The staff also benefit. What we see there, because PET workflows are simpler, lower radiation exposure, as you just heard about, that improves both safety as well as job satisfaction for the staff working in the PET unit. And then because of those efficiencies, again, like we just mentioned, we can see more patients in a day, and access is so critical when we talk about the benefit of a PET CT scanner. So putting all of that together again, PET isn't just better clinically, as you heard, to help better understand disease and stratify the needs of those patients and connect them with the sort of treatment that's best for them. It's really a win for operations overall. And then for the overall patient journey, it really becomes addressing that quadruple aim. Next slide. So what we learned for pro tips from the field. And so, we always like to give you kind of like, I wish we knew this sort of thing. So what we wish we knew from the start, according to the organization that we interviewed, what they would say is, when you first get started with something like this, it's very important to know your population, because PET, while it's wonderful, isn't a one size fits all. It's really helps you to understand how you should use it, and how you use it needs to be tailored to your community needs. It really is an amazing tool, but also isn't the be all and end all. The other thing is, it's important to invest in myocardial blood flow training early. So that's an aspect you don't want to leave off, because this is where PET really shines. It becomes a real differentiator in the ability to manage patients. And so it's really important to invest the time up front so that you can reap the benefits later on. Thirdly, it's important to simplify your reporting systems. With something like PET-CT, those data sets are very large, and understanding all of the information gleaned from the study is important to place into a report and streamline those systems so you are not overwhelmed by the data that's coming in and the integration of that data into the EMR. And then finally, think long-term, because PET is not just about coronary disease. When we think about all the potential future applications, it's an important tool that will help us better understand the nature of patients' disease. So something like sarcoid, understanding viability, and even potentially for infection imaging for patients. So again, it's like anticipating. The sooner you plan for what you can do in the future, the better you'll be prepared for what you can do to make that program more resilient and even more impactful for your patients. So what we'd like to say, really, if we sum it all up, what we're trying to say is implementation, is an important, thoughtful process. And if done well, it's not just a linear go one step after another, but it really launches your program forward, and it accelerates the benefit you have for your patients and for your program. So with that, what I'd like to do is then hand the webinar over to Brendan, and he's going to talk a little bit more about CDL services. Thanks, Brendan.
Thank you, Denise, and thank you to MedAxiom for hosting this webinar today, and thank you also to Dr. Singhani for participating. I'm with CDL Nuclear. I want to tell you a little bit about our company and some of the solutions we have for cardiac PET-CT implementation. Next slide. So we've been in the business of diagnostic imaging since 1992. In 2003, we sold off almost all of the business, and we kept just the kernel of the business that at that time was cardiac imaging. Back in 2003, that mostly just consisted of SPECT imaging. After that point, we did get into doing more SPECT. We started into first pass. And then in 2011, we sort of graduated into cardiac PET imaging. When I came on board, it was about 11 years ago now. We had, I think, 2 customers that were doing cardiac PET. Back in that time, this was a modality that was somewhat reserved for really larger private practice cardiology groups. Uptake in the hospital systems was very minimal. And if you were sort of a mid or a smaller size group, there were these significant barriers to entry, which I'll talk about in a minute. Denise spoke about some of them as well, that would really just have prevented you from taking a look at this in a serious way in your office. So, from 2003 on, our company has been in and around cardiology clinics. We've gotten to know what makes these groups tick. We understand in a lot of cases, especially with the private practices, these are small businesses. They have a unique set of concerns in the way that they evaluate getting into new modalities or incorporating different things into their offices. And so over those years, those are things that we've really tried to focus on fine-tuning a model that would enable as broad of an access pathway as we could manage for all these groups to step into advanced diagnostics, because we truly believe that it helps people. So back in 2013 or 14, whenever I got started with CDL, we had 2 cameras. We've been very blessed to take advantage of some momentum, good timing, being in the right place to grow into what we are today, which is a nationwide company. We've got over 130 PET and PET CT systems installed around the country. There's at least 50 more coming. So it's been a great ride. The wave in the private practice, it feels like, at times it's cresting, but then it just kind of keeps growing and growing, which is great. Hospitals have sort of lagged behind, but now I think they're starting to catch up. And so we're starting to see more demand in the hospitals and the health systems as well, which is very exciting. And one of the reasons I think that we have had such success is because when initially this was a solution for larger groups, we were able to expand the market through the advent of our CardioNavix program. I'll talk more about this, but at a high level, this is a daily use rubidium program. So it reduces the financial burden of a full-time generator for groups with lower volumes. They can get into a PET program on a 1-day, 2-day-a-week basis, and then grow into a full-time program, which again, really helped expand the market. We also, I'm pleased to say, we've entered into a partnership with GE Healthcare recently. So in addition to rubidium, we can also provide their Flyrcado product and fast track interested users into that novel isotope as well. Next slide, please. Just looking at the market from a high level, back in 2015, we were doing around 140,000 scans nationwide. These are PET scans. There was a slowdown, of course, during the COVID years. And then from 2022 into 2024, we picked up with about a 20% year-over-year growth. And last year, we did about 520,000 PET scans. So we anticipate that that growth is going to continue well out into 2030 and beyond at about a 20% growth rate. The reasons for this are probably apparent to most of you by now. Obviously, there's a robust and a stable reimbursement architecture out there. So there's a clear incentive created by the payers to sort of shift things in the direction of cardiac PET. As Dr. Sangani spoke very eloquently about, this is a really good clinical test, especially when compared to SPECT. So physician preferences have shifted, right? Maybe from SPECT to PET, maybe you want to do more CFR. Maybe, just pharmacologic stress has become more appealing over treadmill stress. And then, of course, as I said, there's a new tracer now, which we haven't seen in a number of decades, that's also driving awareness and adoption. Next slide. Okay, so talking about the barriers. Again, these were touched on, but just to kind of give you a sense, when we built our model initially, it was primarily about getting great equipment in there that was really economically viable, having a robust service infrastructure around that, because if the camera's not up, you're not scanning, and then helping with certain other, facets of the model to make it a financially viable option for private practices in particular. And so we did that in a variety of ways. And as we wanted to branch out into different types of groups, we've layered in other things that we felt would help get people to say yes and to offer this modality through their practice. Things like providing staffing, accounting for low patient volume with CardioNavix, as I mentioned. We help build out the space. We help find the space. If you're in a state with a certificate of need or some type of onerous state or local regulations and paperwork requirement, we help out with all of that. Of course, we take care of all the equipment, the service, and there's a number of other things in our ecosystem. We do prior auths. We have a GPO just for cardiology groups that does things like radiology overreads, packs that have been stripped down just for cardiology groups rather than large radiology groups, and a whole host of other things that just, again, hopefully over time, again, these are based on learnings that we've developed over 23 years of doing cardiac imaging, that these are things that are important to you all as leaders within your practices. Next slide, please. Okay, so what are the solutions? There's 3 solutions, but they sort of span 2 different pathways. The first is you don't have a camera and you need a camera. And the second one is well, I already have a camera, but I need to get into cardiac imaging. So on the first group where you don't have a camera, we can do a couple of things. We have the cameras that we can bolt into the ground in your office. If you don't have the real estate, no problem. We can also bring in a mobile trailer. Denise talked about a use case where that worked out wonderfully. Space is always at a premium, and so the mobile trailer, it doesn't even have to be mobile. A lot of folks just have it come in and it sits full time outside their office. I can tell you, when you get a new mobile trailer in there, that ends up sometimes being the nicest bit of real estate in your office. They're very well appointed. They look great. They're very comfortable nowadays for patients, fairly roomy. So I wouldn't hesitate to recommend that route as well. But sometimes you just can't beat the in-office program. We always have great equipment. There's a lot of optionality with both of those. You get to choose your equipment, your reading software. We'll set up your hot lab in different configurations. Obviously, the configuration of the floor plan is going to vary site to site, but we've done it 130 plus times. So I like to think we've seen it all. And then option two, if you have a camera and you just need to get into cardiac imaging. So the thesis with CardioNavix initially, this was back in 2020, we released this product, was that there's a lot of unused camera time out there. There's a lot of PET CTs that aren't filled up 100% of the time. And so with the new reimbursement for PET CT in hospitals, especially, it would be a good idea to potentially gather your volume over a period of maybe 3 or 4 days and then pick up a day or two of cardiac imaging on the back end. And we will help you upgrade your camera, help you upgrade your lab to get you ready to do cardiac. And then, of course, we bring in the rubidium. Next slide, please. The theme of this slide is really just to convey that when you sign up with CDL Nuclear, we want you to be able to sign that contract and then go about business as usual. If you're a private practice, you're going to run your business and you're going to take care of patients. If you're in a hospital, you also have practice considerations, and mostly I want you to just be focused on your patients, knowing that behind the scenes, CDL is taking care of everything from planning, site prep, build out, camera installation, training, reimbursement help, everything that you need in order to get to first patients, hopefully in about 180 days. Next slide, please. A little more on the mobile. So everything you can do in a fixed lab, you can also do in a mobile. It's just a different setup is all. So the build out is a little less complex with a mobile. So we can typically start these up a little quicker. When it comes to site considerations, you're looking at about 7 parking spots worth of space. Sometimes we have to pour a pad and then usually bring in power. But again, much lighter lift from a facility fit up standpoint. So if time is of the essence, sometimes mobile is a good way to go. Sometimes it's a good transitory model. So if you have a lab that you're building out and you want to get into PET a little bit quicker while you build out that lab, we also do gap mobiles, as we call them, for that use case. Next slide. There's just a little bit more about the inside of those mobiles. Just a point of note, if it is going to be your fixed full-time mobile, you have the ability to kind of pick all of the fit and finishes. We have somebody who kind of fulfills the role of like an interior designer. Like if you were going to do that in your house, same thing in this mobile. You can pick the floor colors, the wall, the cabinets, the textures, the wood grains, the full 9. So you can really customize it and make it yours. We can also wrap it for you and put your logo on the outside. Next slide, please. And CardioNavix, again, for lower volume sites that maybe have a camera that you can utilize for other things, or if you're a private practice that just has a camera and you want to not pay that full boat for the rubidium generator, this could be a good solution for you. The operational logistics of this are very straightforward. So you just tell us when you need rubidium. We show up usually the night before. We bring the infusion system in. It's the brand new Bracco 1700 infusion system. It works great. It does overnight QC, so we get all of that set up for you so that when your tech comes in the next day, the infusion system is more or less ready to go. They do a quick camera QC. They're off and running with patients, and then they notify us once that last patient is done. We come back and pick it up, and away we go. And we also provide, I caught that last bullet there. It's not just the isotope, as I said before. So there's an ecosystem around it. You don't have to go back. That will just make sure that you are supremely comfortable when you get to first patients. It's going to feel like you've been doing cardiac forever. You're going to know all about everything from patient workflow, preparation throughput to reimbursement, and reading CFR. So the key takeaways here, if there is a need and a desire to do cardiac PET at your facility, it's the best test. I think now is the best time. And CDL can help you do it in any which way, shape, or form you would like. I'll give you one more case study. We have a health system out west that kind of needed to do a lot of PET in a lot of places. And so this started a journey a few years back that has led us to today, where they have 2 fixed site cameras, 2 mobile cameras, and they use CardioNavix at another location where they already had a camera. So we can do PET any which way you would like to in your facility. And I believe that takes us to the end, and we have some Q&A.
Thank you, Brendan. So we've got a couple questions that we've come in. I will have each one of the panel, if you don't mind coming back with us here. The first question that came across, and Dr. Sangani, I think this might be just in your wheelhouse. It says, you've highlighted PET's ability to measure myocardial blood flow reserve. How does that capability change decision-making for patients compared to traditional SPECT?
Yeah. So first off, I think blood flow is particularly helpful. So a couple situations. It's helpful to definitively rule out that there's not coronary disease, right? The ones where we worry about balanced ischemia, or we're not sure if the SPECT perfusion is, or the PET perfusion is normal and flow reserve is completely normal. I am reassured that everything along the entire coronary tree, epicardial, microvascular, is normal. I think it's very useful in the patient where I am worried about balanced ischemia and multivessel disease. You may see a slight drop in EF with SPECT, you might see TID, but you might not. And when I now see that the flow reserve is diminished in addition to the drop in EF, I'm very concerned that there's balanced ischemia. I like it where there is a specific physiologic assessment I might want. Let's say a patient has an equivocal lesion on a cath, and we really want to assess the functional ischemia in that area. It's very helpful in our younger patients where they're going to be receiving serial imaging over their lifetime. And so I want to be cognizant about the radiation dosage they're going to be receiving as well. But flow really in its utility is that differentiator prognostically. And the microvascular disease component, ANOCA, INOCA, that we're spending much more time on now and really optimizing their medical therapy, this is a game changer.
Thank you. I think this next question that came in is going to be great for both Dr. Sangani and Brendan to talk about this from. They're asking a question about the technologists and the physicians. They say, do you have any PET programs for hands-on training for physicians for reading and technologists for performing?
Yeah, we do. So under our model anyway, it's a fairly robust training program. So it features a combination of on-site training by technologists for your technologists. We'll incorporate the OEM typically in that. The isotope vendor will also be involved. And then our technologist stays on site for a full 2 weeks for your first patients, so that by the time they leave, again, your techs are going to feel supremely comfortable. For the physicians, if you can read a SPECT, you can read a PET, right? It's just a prettier picture. But if you want to get into MBF, that's where there is an additional bit of training that you should consider. And for that, we also provide a program. We usually like you to gather a few images first, and then we have 2 options. Usually most groups exercise both. We'll have somebody that performs a webinar support for you in which you're looking at overreads together and going through your blood flow that way. And then also you can elect to have somebody actually come on site with you and get a little bit more hands-on in interpreting those blood flow images.
And then Dr. Sangani, any tips from a physician perspective?
Yeah, so I think this is really important. Again, the relative perfusion is easy. I would agree with what's been said. It's the flow reserve that takes a little bit of training, but is really not that hard. ASNC has multiple webinars and an intensive PET course that we host 3 times a year. I made everyone in our lab attend that 6 years ago when we started our program. We also now offer mini sessions once every 2 months. There's one coming up actually in November. So I think there's lots of different ways to learn about flow and flow reserve. I would also tell anyone who's starting on this, we processed images and did flow reserve from the beginning, but we did not start reporting flow reserve for about 6 months. I think it's really important that you look at the quality, you correlate your own flow reserve with your cath images later on to make sure that things make sense and correlate before you put those numbers out there. And then it's educating your entire team on this, as well as your referring physicians on what these flow and flow reserve numbers mean. But it can be really impactful for patient care.
Hey, Jamie, I can't help myself here. I'm just going to say what Dr. Sangani just mentions. In the program I was at prior to coming to MedAxiom, we integrated PET imaging, when we did myocardial blood flow imaging, I should say, with our heart team conversations. So there would typically be patients in which it was unclear for the type of revascularization that would be most beneficial, or even if revascularization was necessary. And that was a great way for the team to learn along the way what it meant and how it facilitated decision-making, because we put the images up there to understand myocardial blood flow alongside the cath. And so not only the APPs that were in the heart team meeting, as well as the other physicians, but the fellows that were there, they all had a better understanding. And then that was integrated into the heart team notes. So that's just a really great point. It's right patient, right time, right test, all of those things that really are facilitated with myocardial blood flow imaging. So I'm glad you mentioned that.
There's also, ASNC also has a bunch of documents on how to report this. What are the standard phrases you would want to use as you report PET MBFR?
Mm-hmm.
So this next question, I think is actually a little tricky, because I would say all of them are equally important. But the question we got is, if a program is just getting started and they have limited resources, what's the first thing they should prioritize? And they listed equipment, staffing, or workflow alignment.
I'll take a crack at it, and then Dr. Sangani, I'd welcome your input. So it sounds like they're getting started, but they actually haven't. They're starting the planning process, maybe, if they're asking about equipment. I would say, the first thing is your service contract. So you can get away with fairly used equipment. When we started this avenue of cardiac PET, we were kind of using the leave behinds of radiology. So as the standard of care in radiology progressed from PET to PET CT to higher slice count CT, we would take advantage of what they weren't using anymore, which was, refurbished units. And there are some great third-party companies out there that can keep those running darn near 100% of the time, but you got to have a really good service contract. After that, I would say workflow. Workflow around your lab really dictates the efficiency of the lab. So if you have one technologist that's going out to the waiting room and grabbing patients, he or she's prepping the patients, doing the study, and then getting the patient off the table, you're going to do a lot fewer patients than if you have, a nurse or an MA also participating in that process of getting patients through the lab. So I think it's kind of, if you're getting your own camera, make sure your service contract is pretty robust, and then really have your workflow dialed in even before or during the site planning process.
I would agree with what Brendan has said. I think that the most cumbersome, or the longest part of this, is the equipment. And so figuring out what equipment you're going to be using, whether you're outsourcing some of this or all of this to a group like CDL, and making sure the contracting and all of that is done, is going to be the longer time frame. You can start working on your optimization and your workflow and your staffing needs during that contractual time, but the first step would be the equipment.
Yeah, the comment that I would add to this is that you're not alone, and you can partner or collaborate with CDL to come in and actually assist you with each one of these areas. It's not something that you have to kind of figure out from scratch. They have a lot of lessons learned from the different clients that they've worked over throughout the US.
Yeah, really good point, boy, because that can sure feel overwhelming very quickly. I think the other thing is I remember, I'm old enough to remember mobile MRI labs and stuff that would come in. And the joke initially was that the hospital's like, yeah, we're going to the trailer park. This is not like that. I mean, it is a beautiful unit. And patients would comment then with a unit like this CDL would provide. It's like, I didn't know I left the hospital, or, I thought I was still in the hospital kind of thing. So I think that's the other thing, is that you've got beautiful equipment and even choosing what it looks like and whatnot, as well as then understanding the workflow is so critical whenever you've got a new piece of equipment. Yeah.
Yeah, I'll just add on. We do primarily now cite just new equipment, to Denise's point. So it's, we've been fortunate with all the PET that we're doing. We have pretty good contracts now with GE and Siemens in particular. We've been able to leverage some economies of scale into pricing for new equipment that feels like refurbished pricing.
Nice.
So our next question is a little bit of a crystal ball question, but it's asking kind of what your viewpoint or thoughts are going to be in the future for more imaging, infection, where we're going to kind of see that growth head over into the cardiac PET space.
Well, I'll take that to start. I think there's tremendous growth anticipated in cardiac PET. First of all, of course, for myocardial perfusion imaging, as we've already talked about, the increased awareness of INOCA and imaging for ischemia. There are other radio tracers also being developed. So it's not just perfusion imaging. There are tracers that are looking at a lot of areas within heart failure. So everything from, which cells are, so everything from sympathetic innervation to fibrosis and other areas. Infection is already growing. It's grown quite a bit just in the last year, to being able to use our scans to look at everything from valve infections, ICDs, defibrillators, and LVAD infection has grown tremendously. So I think there's a lot of interest and excitement. There are PET tracers being developed for amyloid. There's going to be a lot on the horizon for cardiac PET.
Brendan, are you seeing any of your clients that are asking for these additional testing?
I am. Yeah, we have a handful that have been sort of progressive and been doing, viability for a while, sarcoid for a while. It is starting to come up more and more often. And to Dr. Singhani's point, if you pay attention to like the phase 1 and phase 2 clinical trials, I mean, apparently you can tag anything with fluorine. And so there are so many very exciting, it's not just fluorine, but very exciting tracers coming out. And this field of theranostics too, there's some interesting things happening, not yet in cardiology, but there are a couple of cardiac indications in phase 1 trials. So it's an exciting time to be in PET. It's a particularly exciting time to be in cardiac PET, I think.
I've got a little follow-up to that. Sorry, Jamie. I couldn't help myself. A little follow-up to that. When you've got, now thinking about the different testing protocols that could be used for different disease states, is it advised, or do you find, Dr. Singhani, in your practice, do you tend to group that testing as much as you can, that a bunch of sarcoid evaluation versus lead infection or bad infection? Do you group those, or does that not really matter in terms of workflows and thinking about testing times and patient flow?
If you could, I guess that would, for sarcoids, we could group them because they are often outpatient.
Enough of them.
The infections are inpatient more. So no, we right now add them in when they're needed.
Okay.
I do find that the sarcoids and the viabilities, because they take a little bit more time, we tried actually not to do more than 1 or 2 a day. But that has been part of our workflow. If you wanted to batch them and just create a day that is just sarcoid and viability, that could work as well.
Mm-hmm. Great, thank you.
Well, it looks like we've kind of come to the bottom of our list of questions, but I wanted to give a moment to our panel to see if there's any closing comments that you would like to make.
I'll say that cardiac PET is incredibly exciting. Once you have started on this process and seen the quality of the images and the amount of information you get for your patients, you'll never want to go back. Our referring physicians love it. The hospital, both inpatient and outpatient, and it's made such a tremendous difference in operational efficiency and our volumes. And I think that the future is really bright for this. Getting into the game is important, and the process can be overwhelming. I did ours from scratch 5 years ago, so I've lived it. And it's so exciting that there are now programs and companies like CDL that can partner with you and offer a way to get started so it doesn't seem so overwhelming in the beginning.
Yeah, I'll just add, it's very fortunate, like I said, that we are where we are today and that we got into pet when we did. But the benefit of that is that, if any of you are thinking about getting into pet for the first time or adding to your pet program, these are things that we've just become so intimately familiar with, and we're so passionate about it. If you have any questions or if you're interested at all, I'd encourage you to please give us a call, because we'd love to talk to you about it. Even if you don't end up partnering with us, we have a ton of great stuff we can share. And I think it's a win. The more people that are doing pet, whether it's with us or without, that's a win. So appreciate the time and attention today.
Well, MedAxiom sends a very special thank you for those that are attending today's webinar. A very special thank you to CDL and to our speakers, Dr. Sangani and Brendan. This entire webinar has been recorded and will be available for replay. So if you would like to go back and get some additional information, or if you know someone that would be able to gather information from this, you will be able to share that. There is an associated white paper that goes a little bit more into depth about the case study that Denise and I did, and can provide some additional viewpoints on them getting their program up and running and specifically using CDL. So again, just thank you to everyone for joining, and have a great day.